Welcome back to the deep dive. Today we are opening up a really crucial chapter from the comprehensive textbook of psychiatry.
hmm
We're exploring something that sits right at that busy intersection of, physical health and mental distress.
Somatic symptom and related disorders.
Exactly.
Yeah.
We're diving into how intense psychological distress often finds its expression, well, through the language of the body.
And this is way more than just an academic thing. I mean, these conditions, they drive a huge amount of healthcare use globally.
Right.
Our source material makes it really clear. It's incredibly common for patients to communicate distress through physical symptoms.
Yeah.
And that often leads to these complex, sometimes unnecessary medical workups, expensive tests.
And even harm, right. From procedures that maybe weren't needed.
Precisely. Iatrogenic complications. We used to hear terms like somatization or uh, medically unexplained symptoms.
Yeah, those older terms.
But as this source points out, those terms kind of put the doctor and patient on opposite sides, didn't they?
Yeah, like constantly debating if the suffering was real.
Exactly. Which brings us to the really big shift, the game changer in DSM-5.
Okay.
The core issue with somatic symptom disorders, SSDs, it's no longer about the absence of a clear medical cause.
That requirement is gone.
Completely removed. Instead, the focus is shifted. It's now on the reaction,
The reaction.
the disproportionate and excessive thoughts, feelings, and behaviors around the perceived bodily sensations.
Okay, let's unpack this then. So it's not necessarily what's happening in your stomach, say, but what's happening in your mind about your stomach ache.
You've got it. That's the essence.
So if the symptoms don't have to be unexplained anymore, what does the actual diagnosis look like now?
Well, it simplifies things clinically, in a way. The DSM-5 criteria, they recognize that psychiatrists often see patients who do have established medical diagnoses.
Like diabetes or IBS.
Right. But these patients are still excessively troubled by their symptoms, way beyond what the objective medical condition seems to justify.
So the criteria aren't about ruling out physical disease anymore. It's about the response to the feelings, whether there's a known cause or not.
Exactly. The response is key.
Can you walk us through the actual requirements for somatic symptom disorder, highlighting that new focus?
Sure. The criteria, as laid out in the source, are pretty straightforward. First, criterion A. The patient has one or more somatic symptoms.
Physical symptoms.
Right, physical symptoms that are distressing or actually disruptive to their daily life. That's the baseline.
Okay.
Then criterion C says that this symptomatic state has to be persistent, typically more than 6 months.
Got it. And the crucial part, the pivot point, criterion B.
Yes, criterion B, that's the heart of it. It requires excessive thoughts, feelings, or behaviors related to those symptoms.
Excessive how?
Well, the patient has to show at least one of three things. One, having persistent, disproportionate thoughts about how serious the symptoms are.
Okay.
Two, maintaining persistently high anxiety about their health or symptoms. Or three, devoting excessive time and energy to these health concerns. That's the cognitive and behavioral piece.
That really shifts the focus to psychology and coping, much more than just biology. I also noticed reading through that pain disorder isn't its own thing anymore.
No, it's gone as a standalone diagnosis. Pain symptoms are just so common.
So what happens if pain is the main issue?
If pain is the dominant symptom, the diagnosis is SSD, but we add a specifier with predominant pain.
Ah,
The
right.
pathology isn't just the pain itself, it's the patient's, catastrophic reaction to the pain.
Makes sense. And this DSM-5 classification's like a big tent now, right? Grouping disorders that used to cause confusion. Besides SSD, what else is in this group?
Good question. The new grouping includes illness anxiety disorder, or IAD. That's what replaced hypochondriasis.
Okay.
It also includes functional neurologic symptom disorder. That's the newer term for conversion disorder.
Right.
Then there's psychological factors affecting another medical condition, PFAOMC. That describes when psychological issues, like denial or not sticking to treatment, negatively impact an existing medical condition.
Interesting.
And finally, factitious disorder, where someone fakes symptoms, that's also been moved into this section now.
And importantly, body dysmorphic disorder was moved out, right, to the OCD section.
Yes, a very logical move. Its features really align much better with obsessive-compulsive traits, which helps clarify treatment.
Makes sense. Okay, let's zoom out a bit. History. Because these kinds of presentations, they've baffled doctors for ages.
Oh, absolutely. Millennia. The concepts are ancient. You've got hysteria.
From the Greek word for womb.
Exactly.
Yeah.
Reflecting that old incorrect idea about a wandering uterus causing symptoms, and hypochondria.
Under the rib cage.
Right, where they thought the spleen caused melancholy. These ideas had a long reach.
And the source mentions Pierre Briquet back in 1859. He started trying to describe these things more systematically.
He did. Briquet's work kind of started separating somatization from conversion. His description of a polysymptomatic syndrome.
Kate syndrome.
Right. That eventually led, generations later, to the St. Louis criteria used in DSM-3 and DSM-V.
Ah, the symptom counting era.
Exactly. That approach needed numerical cutoffs, like requiring, say, 15 specific symptoms across different body systems.
Sounds cumbersome.
It was heavily criticized.
Yeah.
Very cumbersome, not very reliable. The focus was still just on the number of symptoms, not really the psychological distress behind them.
Yeah, that unwieldy counting process really shows why we needed this modern, more nuanced approach. So when we look at why these disorders develop the etiology, it's a classic biopsychosocial picture.
Absolutely. It's a real convergence of factors. Biologically, the chapter mentions things like heightened interoception.
Meaning like being more aware of internal body sensations.
Yes, increased sensitivity. Also increased pain sensitivity. And fMRI studies are showing some unique brain patterns, different functional connectivity in patients with these functional somatic syndromes.
And psychologically, are there personality factors?
Definitely. Traits like suggestibility play a role. And something really interesting the source highlights is alexithymia.
Alexithymia. Difficulty with emotions.
Yeah, difficulty identifying, processing, or even just putting emotions into words. So if someone can't easily say, I feel really anxious, their body might kind of step in and express that distress as, my head hurts or my stomach is in knots.
Wow. And environment. Early life stuff.
Huge factor. Early trauma or abuse is strongly linked. Also, learning factors may be getting attention when sick, we call secondary gain. And culture shapes how distress is shown. Physical symptoms often pop up after trauma, and they can be like culturally accepted ways to express suffering. The book mentions idioms of distress.
May attack de nervios.
Exactly. The attack of nerves seen in some Hispanic populations. It's how intense psychological distress can manifest physically in that cultural context.
Okay, so moving into the clinic. If a patient shows up with physical symptoms that don't have a clear cause, what clues might suggest it falls under this SSD umbrella, that a psychiatric approach might help?
It takes careful clinical judgment. You look for patterns. Do the symptoms follow closely after a traumatic event?
Okay.
Do they coexist with known psychiatric conditions, like major depression or panic disorder?
Right.
Is there evidence of some psychological benefit or secondary gain from being sick? And a big one, is there a pattern of persistent, heavy use of medical services, often combined with dissatisfaction with the care they've received?
That last one sounds tricky. So to really get a feel for the range here, the source gives two contrasting cases. Can you tell us about Mrs. M first, the milder case?
Sure. Mrs. M was a 40-year-old woman. She had multiple pain complaints, some minor anxiety and depression. Her symptoms were bothersome, definitely.
But manageable.
Yes. Her case shows that mild SSD can often be managed effectively right in primary care. She actually responded well to brief cognitive interventions, simple relaxation techniques like diaphragmatic breathing.
Just breathing exercises and naps.
Pretty much. And she got better quickly and stayed better without needing meds.
Okay, so that's functional, but distressed.
Yeah.
Now contrast that with Mr. K. He sounds like the severe end of the spectrum.
Mr. K is a really stark example of how bad things can get, especially with medical seeking. Mid-50s guy, chronic pervasive gut symptoms, starting way back before age 30.
Wow.
His symptoms were so ingrained, he developed this fixed, almost delusional belief that he had an intestinal blockage.
Oh, no.
And this led to him undergoing multiple exploratory surgeries, including major ones like subtotal colectomies, ileostomies, often finding nothing really wrong pathologically.
That's just terrible. That's the definition of iatrogenic harm, isn't it? The treatment making things worse.
Absolutely. He became this extreme medical seeker, traveling everywhere for care, couldn't work, his whole life consumed by these symptoms and the search for a cure.
So how do you even manage someone like that?
Well, in his case, because he completely lacked psychological insight, he refused formal therapy. So the focus was on supportive psychotherapy, which really highlights the biggest challenge in managing these conditions.
Building that therapeutic relationship.
Exactly. Establishing the therapeutic alliance.
Because if you're a patient like Mr. K, you've probably been dismissed, maybe told it's all in your head, or had painful, unnecessary procedures, you're going to approach a new doctor with a lot of pessimism, distrust even.
Immense distrust. So the approach has to be about caring, not promising a cure. That's key.
How do you show that caring?
You have to respect the symptoms as real to the patient.
Mm,
Never say they're imaginary.
okay.
Active listening is critical. The source suggests performing brief physical exams, but maybe at regular infrequent intervals, say once a month.
To validate their experience without over-investigating.
Precisely. And crucially, avoid premature reassurance, saying, don't worry, it's nothing serious. Too early just makes the patient feel unheard.
Right, like you haven't grasped the severity of their suffering. That neutral, validating stance seems vital for long-term care. Okay, let's switch gears slightly to illness anxiety disorder, IAD. How is that different from SSD?
Good question. IAD replaced hypochondriasis. The key difference is that IAD patients usually have only minor somatic symptoms, or sometimes none at all.
So it's not about the symptoms themselves being super bothersome.
No, it's about an intense fear and preoccupation with having a serious undiagnosed illness. The fear itself is the main problem.
Ah, okay. So SSD is distress about significant symptoms you do have, while IAD is distress about a serious illness you fear you have, even with minimal symptoms.
Exactly, and that fear can become really intense, almost phobic. The source mentions things like AIDS phobia as an example.
And since part of the diagnosis is that they aren't reassured by negative tests, it tends to be chronic.
It does, unfortunately. Reassurance is very difficult, yet it's often what patients seek.
So what works for IAD? What does the evidence say?
Well, pharmacologically, there are controlled trials, like one by Fallon and colleagues mentioned in the text, showing SSRIs like fluoxetine can have moderate effectiveness.
Okay, meds can help sometimes.
But psychotherapy is really considered the first line, especially cognitive behavioral therapy, CBT.
CBT again?
Yep. Controlled studies, like one by Barsky and Ahern, show CBT has lasting benefits, particularly in changing those core catastrophic beliefs and attitudes about health.
That really underscores how powerful CBT is across this whole group of disorders. What exactly does CBT do for these patients? How does it work?
It directly targets the problematic thinking patterns. That automatic thought like, oh, I have a headache. It must be a brain tumor. I need to lie down and not move.
The catastrophic thinking.
Right. CBT helps patients challenge and modify those thoughts. It uses techniques like relaxation training, keeping diaries to track symptoms and thoughts, and gradual increases in activity.
To show them their body isn't as fragile as they fear.
Exactly. It provides evidence against their fearful beliefs.
And the great thing is, these interventions can work even outside specialist settings, right? The source mentions some key primary care studies.
Yes, and this evidence should really combat any leftover therapeutic nihilism or pessimism among doctors. There was the Smith consultation letter study.
Tell me about that one.
It was remarkably simple. They just gave primary care physicians, PCPs, some basic guidance. Schedule regular brief visits, do brief exams, avoid invasive tests unless clearly needed, and importantly, make time to let the patient talk about life stressors.
And that simple approach worked.
It led to significantly improved functional capacity for patients, and this is huge. It decreased their use of healthcare resources. It actually saved money.
Wow, just by changing the interaction style.
Pretty much. Then there was the Escobar CBT study.
What did that find?
It showed that a time-limited, brief CBT-type intervention delivered right there in the primary care office significantly reduced physical complaints in over half the patients. And it also improved their depression scores as rated by the clinicians.
So the takeaway is clear. Treatment can work.
Absolutely. The reviews of these studies are clear. We shouldn't feel hopeless about treating SSDs. The key is often setting modest, realistic goals.
Like what?
Maybe not aiming for a complete cure of all symptoms, but focusing on things like reducing doctor visits, improving day-to-day functioning, and maybe getting the patient committed to seeing just one main PCP.
Practical goals. It seems we definitely have the tools now to help people with these really common and often disabling conditions.
Yeah.
So wrapping up our deep dive here on somatic symptom and related disorders, the big message from this chapter really seems to be that crucial shift in DSM-5, moving away from trying to explain the unexplainable physically and focusing instead on the patient's psychological and behavioral distress about their physical feeling.
Exactly. And if you connect that to the bigger picture, this move towards psychological distress, it really shows how knowledge is most valuable when we actually apply it.
Right.
This shift helps us improve the quality of life for patients who, let's face it, have often felt dismissed or frustrated by a purely physical medical focus.
Yeah. And finally, maybe a thought to leave you, the listener, with. It comes from the text pointing towards how we might think about diagnosis in the future.
Oh.
McHugh and Slavny had this perspective, stating that a somatic presentation is, quote, not something the patient has. It is something the patient does. That is, it is a behavior.
Hmm, interesting framing.
It kind of challenges us, doesn't it, to think about how we define mental illness itself? Maybe moving more towards models that look at observable behavior, functional brain circuits,
Hmm.
like the NIMH's RDOC framework.
That definitely reframes the whole discussion around the nature of this suffering. A lot to think about.
Indeed. Thank you so much for engaging with us on this deep dive today. We really appreciate your curiosity.